Ladies and gentlemen, NBs, they, thems, welcome to another video for Critical Care Review. So the last video we talked about the cellular physiology of shock, so we were really on the micro level. Now we're going to go to the macro level. So in this one, we're going to talk about hemodynamics, we're going to talk about cardiac output and oxygen delivery. Alright, so little disclaimer here. This video is for education only. This is not medical advice. The information in this video may be different from your local facility/agency protocols. Always follow your local facility/agency protocols when engaging in patient care. Do not go outside of your scope of practice. I am a dumbass on the internet who likes to make educational videos for fun. So, don't take medical advice from a guy that forgets to do his laundry almost weekly, okay? Okay, so here's the learning objectives. So, by the end of this module, we're going to learn about systole, diastole, mean arterial pressure. We're going to learn about cardiac output and cardiac index. We're going to learn about the components of stroke volume, preload, afterload, and contractility. We're going to learn about our hemodynamic values and what those mean. We're going to learn about oxygen delivery dynamics and how they influence shock states. And we're going to learn about the oxyhemoglobin dissociation curve. I've got about 42 slides. I might have to break this up into a couple separate videos just for the purposes of length. But we'll see. Let's get into it. Okay, so systole, diastole, and MAP. Okay, so systole, your heart contracts and it pumps all the blood into the systemic circulation. Okay, so we measure the systole usually just with regular blood pressure, right? So a normal systolic blood pressure for adult is about 90 to 140. All right, then diastole, we have the heart relaxing, okay? And then the normal diastolic blood pressure is 60 to 90, okay? So, when you check your blood pressure at the Fred Meyer or whatever, you got systolic blood pressure over diastolic blood pressure, EBP. Okay? And then the third one that we have is the MAP. So if you've ever, been in the hospital or whatever, you probably have seen that third number. So it'll be like systolic blood pressure over diastolic blood pressure. And then in parentheses next to it, there'll be a smaller number, and that's the MAP. So in critical care, we love the MAP because the systolic blood pressure and the diastolic blood pressure, they only really show you what the peak pressures are. They don't actually give you any information about the entire cardiac cycle. So we look at the MAP. The MAP, usually in the ICU, we want to have it like greater than 65. Okay, so here's the formula for the MAP. So your MAP is 2 times your diastolic blood pressure plus your systolic blood pressure divided by 3. So this diastolic blood pressure is multiplied by 2 because you spend twice as long in diastole as you do in systole. Then you divide that by 3, and then you get your mean arterial pressure. Ooh, funny bone. All right, so this part's important. So the coronary arteries perfuse during diastole. So your heart actually perfuses when it's relaxing, and it kind of does that because that blood, like you contracted, it pumps it out, and then when you're relaxing, the blood in the systemic circulation kind of gets sucked back into the coronary arteries. So you do need to remember when the heart actually perfuses. Okay. Moving on. All right, so cardiac output, this is the delivery man, right? So the definition of cardiac output is it's the volume of blood pumped by the heart in 1 minute. All right, so the formula for cardiac output, this is super important because if you actually understand all the parts of the cardiac output, when we start talking about shock and different shock states, they're going to make a lot more sense. This is basically the top-down hemodynamics, really. So, we can get in the weeds more, but ultimately this is always what we're talking about. So, stroke volume, what is that? It's the end diastolic volume minus your end systolic volume. So how much is left over versus how much was there in the beginning. And then you subtract these two numbers and you get your stroke volume. So the normal range for, your cardiac output is about 4 to 8 liters per minute at rest. Now, cardiac output, it's the primary determinant of oxygen delivery. And remember, from the last video. So delivery or supply, it's going to be that DO2. And to meet metabolic demand to prevent anaerobic metabolism, it's either got to adjust the heart rate or the volume per beat stroke volume. Okay, so this is very basic because this is not going to be like everything. But say, you need to have 6 liters per minute of cardiac output. So, and your heart rate is, say, 80. Okay, times stroke volume. Now, I'm not going to do the math on that, but to maintain that 6 liters per minute at 80, the stroke volume's got to stay consistent. So let's say 6 liters per minute. Let's now say that your heart rate's going to be like 120. 20 times. So obviously, to maintain this, just because of the way that math works, your stroke volume is going to go down and vice versa. Okay, so if your heart rate, to maintain the 6 liters per minute heart rate equals, let's say you're bradycardic now, your heart rate's like 50, your stroke volume is going to have to go up. Make sense? And the same thing works in reverse. So if your stroke volume is a lot, your heart rate goes down. And if your stroke volume sucks, then your heart rate goes up. Okay, that's just how we compensate for maintaining our cardiac output. All right, moving on. Okay, yawn. All right, so let's get into cardiac index now. So cardiac output is not the only measure of your cardiac output. We also use cardiac index, and the reason why is a cardiac output of 4 liters per minute for a really small, frail, elderly person. This is a lot different than someone that eats Dianabol for breakfast and is a huge bodybuilder, right? So the cardiac index, it's a hemodynamic parameter that relates the cardiac output to the body surface area. And this provides a standardized assessment of perfusion regardless of how large a person is. And let me tell you, a lot of people that have heart problems are very large, right? So a normal value is about 2.5 to 4.2 liters per minute per meter squared. And then, in like cardiogenic shock states, this is going to go down. So when you get like less than 2.2 liters per minute per meter squared, that's kind of, when you're starting to think that there's a pump problem and that the person is in like a cardiogenic shock state. AL is a 76-year-old male presenting to the emergency room with altered mental status. On assessment, he is cool to the touch and his lungs have audible crackles. He has a past medical history of heart failure with a reduced ejection fraction, CKD3, and uncontrolled type 2 diabetes. He's admitted to the ICU and his initial vital signs are blood pressure 84/50, heart rate 112 sinus tach, respiratory rate of 31, and he is satting at 87% on 6 liters nasal cannula. Of the following options, which would you most expect to see? I will leave you this for a minute. Did you guess C? So the proper answer is C. Remember from the last video, if you watched it, and God forbid you came back for some reason, that if, your lactate is going to go up just by nature of, your cells not getting enough oxygen and starting to rely on that anaerobic metabolism, right? So if a if a cardiac index less than 2.2 indicates cardiogenic shock, then it's likely that that person's lactate's going to be elevated as well because their cells are angry and not getting the oxygen that they need, right? Okay, so that's going to do it for cardiac output and cardiac index. The next section we're going to move on to is stroke volume, afterload, preload, and contractility. Nectar of the gods, love me. Mountain Dew kickstart. Okay, stroke volume, preload, afterload, contractility. So remember, we have cardiac output equals heart rate times stroke volume. And our stroke volume is made up of 3 different things. So it's made up of your preload, it's going to be made up of your afterload, and it's going to be made up of contractility. Okay, makes sense. Great. I love it. Let's move on. All right. So, just like I mentioned, stroke volume is preload, which is the stretch of the heart. Okay. Afterload is the resistance that it has to pump against in order to get the blood out. And the contractility is going to be how hard the heart contracts. So stroke volume is not random. It is actually made up by 3 different physiological variables that we can manipulate. And that stroke volume, remember, that value is your end diastolic volume minus your end systolic volume. Excuse me. So every hemodynamic drug or intervention that we do when it's targeting the heart is going to target one of these 3 levers, right? So we got 3 levers we can control. It's like the Federal Reserve with the money supply. You can control interest rates and basically it, right? But, so, let's see. If we give person fluids, they're going to have more circulation going into the right side of their heart, so that's going to increase their preload. If we give them norepinephrine, that's going to contract down on some of the arteries and stuff, and that's going to increase our afterload. And then we got things like dobutamine, which are going to increase our contractility. So just know that, the same thing works in reverse too. So if someone's, like preload is, they're way volume overloaded, we can give them like diuretics and stuff so we could lower that. Right? Okay. It works both ways. Just know that. Okay. Let's start talking about preload first. So, the degree of ventricular stretch at the end of diastole is what preload is, okay? Remember, it's the end diastolic volume. So, Frank Starling's law is the heart pumps what it receives. So, if we increase that stretch in the heart, it's going to create a more forceful contraction. Now, think of it like a rubber band, right? So if you pull on it and then you let it snap back and it's not great, so you pull on it really hard and you let it snap back and then you're like, all right, well, I'm going to pull really hard. And then you pull really hard and it breaks, right? It's the same for your heart. So overstretching is disengages the fibers and it can cause a heart failure. So the contributors to your preload, it's going to be your venous return. This is the primary driver. And then you also need to know about the atrial kick or atrial systole. This is going to add about 20 to 30% of your total preload. So like, if a person goes into AFib or whatever, their blood pressure can drop very precipitously because they lose that atrial kick that's going to send all that blood down into the ventricles to be pumped out because they're not getting as much stretch, right? Okay, so the other thing to know is right-sided MIs are very preload dependent. So giving them things like nitro can cause a greater decrease in their blood pressure because nitro, it's going to dilate these, big veins here. It's going to cause a decrease in venous return, which can cause a decrease in preload. And your heart is already kind of struggling, pumping all the stuff out because it's got like an infarct over here. So just be careful when you're giving a right-sided MI nitro. Okay, so right heart versus left heart. So the right heart preload is measured by our CVP. This is our central venous pressure, and sometimes you will see RAP, and that's our right atrial pressure, right atrial. And this is normally about 2 to 6, okay? So what does that actually mean? So if you're, now, this is going to be controversial because some cardiologist is going to yell at me for saying this, but this is what the textbooks say, so I am going to mention it, but do know that this is not always accurate at all. Okay, but for the purpose of this review, a preload of, or a CVP of less than 2, meaning they might be kind of dry, and a CVP of greater than 6 might mean that they're overloaded. Okay, so what does this look like? So CVP is measured up here, RAP is measured down here. So if you're getting a lot of fluid or your right heart is just not doing great and it's not pumping all that out, it's going to back up this way. So our RAP or our CVP will be increased. And that's also why, you're going to get like that JVD or that jugular venous distension. It's why your IVC might be dilated on ultrasound. And it's also why you might get extremity edema or ascites or hepatic portal vein congestion, which is a fancy word for your portal vein in your liver is getting swollen because all the fluid in here is expanding your veins. Okay, what about the left side? So you're going to see this written two ways. It means the same thing. So we got pulmonary artery wedge pressure, or PAOP, PAWP. PAOP means pulmonary artery occlusion pressure. It's the same thing. And this is about 8 to 12. So how do we actually measure this? Well, this is measured with a Swan-Ganz catheter. You're not going to be measuring this. Do note that, unless you're a doctor. But if you're a doctor, why are you watching my videos? So what that looks like is they will put this line in, and it's got a balloon on it. So let's see here. It's got this balloon on it, and they will blow this balloon up, and when your heart contracts, it's going to go up into the pulmonary artery, and it's going to block it off. And then, because of the way your heart works, it's going to measure kind of what's going on over here. So PAOP PA. This is going to be about 8 to 12. Okay, so if your left heart is super overloaded with preload or fluids or whatever, it's going to back up this way. It's going to back up into the lungs, and that's why, people with left heart failure, they might have like increased oxygen demands, or they might have some pulmonary edema. Their oxygen requirements might be going up. So do know that you can have high right heart preload with low left heart preload. These are dependently independent systems, if that makes sense. So your right heart can fail without failing your left heart for a certain amount of time, and vice versa. Okay, let's talk about afterload. So what is afterload? Afterload is the resistance that the ventricle must overcome to pop open the valves and eject blood. Now, afterload and resistance is governed by Poiseuille's law. French guy, he figured this out. So resistance is dependent on 8 times eta, which is the viscosity of the fluid or blood, times the length of the vessel, divided by pi r to the 4th power. What does this mean? So if you're dividing it, if your vessel is super small and that number gets, multiplied by itself 4 times, it's going to be a lot smaller than this being multiplied by 4 times. So if the vessel is bigger, there's going to be less resistance. So less resistance. And if it's smaller, there's going to be more resistance. Okay, now why do we care? Well, because it causes a massive increase in afterload, right? So if there's more resistance on the other side of the left ventricle, or the right ventricle for that matter, then the heart's going to have to work harder. And this high afterload, it can lead to high myocardial oxygen demand, or MVO2. So that is why if someone's like super duper hypertensive or whatever, their troponin might go up because they're having like an ischemic event because their heart has to work so hard to contract and get all that blood out of there. So reducing the afterload makes it easier for a failing heart to pump, and that's why, like a lot of people with like chronic heart failure, they might be on like an isosorbide or like a chronic dilating medication for their arteries. Okay, so pulmonary versus systemic vascular resistance. So systemic vascular resistance is the afterload for the left ventricle, and this is 8 to 1200 dynes. So let's go over here. Okay, let's change my pen color. So SVR is right here, right? I mean, it's everywhere, but Systemic vascular resistance is 800 to 1200. So if the pressure is super high in here, then the heart's going to have to pump really hard over here to get that out. And if the pressure is super low over here, it doesn't have to work as hard to get it out, right? So like a high systemic vascular resistance would be caused by like hypovolemia or hemorrhagic shock, because your body freaks out because it's losing blood. So those clamp down to maintain that cardiac output of 4 to 8 liters per minute, right? And then in things like distributive shock, like sepsis, anaphylaxis, and neurogenic shock, you're going to have really low SVR because your pipes are now super dilated, right? Okay, so pulmonary vascular resistance is just basically the same thing, but it's for the right ventricle. So PVR. And that's about 250 dynes. So let's think about it. So like if you're hypoxic, your pulmonary artery, it constricts and it causes pulmonary hypertension. So the pressure in here is super high, and then that causes the right heart to start to fail, because if you'll notice, the right side of your heart is a lot less muscular than the left side of your heart. So it can't really compensate over here for very long. And when you have pulmonary hypertension and right heart failure, that is something called cor pulmonale. And when you have something like a pulmonary embolism or something and it's blocking this and causing you to have super high pulmonary vascular resistance, that's why you'll see like right heart strain being caused by pulmonary embolisms and stuff like that. Okay. Okay, let's talk about the heart pressures over here. So the actual hemodynamic values that should be expected out of your heart. All right, so we got CVP/RAP. We talked about this, right? So CVP is up here, and then an RAP is down here. And this is going to be about 2 to 6, right? 2 to 6 millimeters of mercury. They call that the nickel because, you know, if your CVP or whatever is 5, that's a nickel. It just makes it a little bit easier to remember. Your RV pressure, so your RVP is down here. It's going to be about 15 to 30 over 0 to 8. Okay. And then you got your PA pressure over here. So PA pressure, it's going to be about 25 over 10. So they call that quarters over dimes. 25 over 10. So remember, PA pressure, 25 over 10, quarters over dimes for a normal person, right? Okay, and then remember we talked about the left heart. So how do we measure the preload of the left heart? Pulmonary artery occlusion pressure, remember? So that's that balloon that we float up here. They blow it up, and we get kind of an idea of what's going on over here. That's going to be 8 to 12. 8 to 12. That's your dime, okay? And then our left ventricular pressure, they call that a dollar because it is about 100 to 140 over 3 to 12. So LVP, 100 to 140 over 3 to 12. Okay. And then your aortic pressure, this is basically just what your systolic and diastolic blood pressure are, right? So it's going to be like 100 to 140 over 60 to 90. That's your aortic pressure. All right. You do need to know these. If you're studying for any kind of critical care exam, they will expect you to know these values. So I would definitely commit these to memory. Okay. Now the third part, we got contractility. This is the inotropy of your heart. It's basically just a fancy word for squeezing. So it's the intrinsic force of the squeeze independent of stretch and or resistance. So we'll get more into the mechanisms on the next slide, but just know that it's very dependent on calcium going in and out of the cell. So more calcium equals a harder contraction. Now, it's hard to measure in the field for my paramedics out there, sorry. In the hospital, we'll do like an echocardiogram, and what an echocardiogram is measuring is it's measuring the ejection fraction. And the ejection fraction is this formula right here. Goodness gracious. So, like I said, oh my gosh. Left ventricular ejection fraction. End diastolic volume, so what's left? What's left? Minus what was there? There. There. Divide that by what's left. Multiply all this by 100. So this is what your left ventricular ejection fraction is. Normal one is usually above 55%. Now, I've seen as low as 6, but, you know, that guy was doing a lot of meth, so don't do meth. That is the moral of this story. I am a supporter of not doing meth. Okay, so we can also alter the contraction, as we can alter afterload and preload and all that stuff. And this would be drugs that increase your contractility, like dobutamine, milrinone, epi, and DIG. For the 5 cardiologists in the United States that still use DIG, because we don't use it very often, but, you know, there are still people out there that do it. Okay, let's talk about this real quick. I'm gonna move that out of the way here. Okay. What are we looking at? So this is actin and myosin. Okay. We got myosin. Okay, by the way, this is the physiology of a contraction. So this is how a muscle actually contracts. Contraction physiology. Alright, what are we looking at? So we got myosin here in the middle. It's this big yellow thing, and it's got these like little fingery doodads on it, right? And then this red band right here, that is a protein that is called tropomyosin. And then these little pink doodads right here, that is called troponin. Now there's different types of troponin, but just for the sake of ease, I'm only going to mention one. Okay, and then this green stuff right here, that is actin. Alright, let's talk about how contraction actually works. Remember, I said that a contraction is very dependent on calcium. So calcium, Ca2+, Ca2+, Ca2+. So calcium is going to come up here and it's going to bind to this troponin, bind to all these troponins right here. And once calcium binds to the troponin, it's kind of going to pull this tropomyosin out of the way so that these myosin heads can actually bind to that actin. And then once the calcium is bound to the troponin, so calcium, it binds to these troponin, it moves tropomyosin out of the way, and then these myosin heads are going to interact with the actin here, and it's going to pull this whole system this way. Okay? Now what does this look like on a grander scale? It looks like this. So, remember, we got calcium, binds to that troponin, moves that tropomyosin out of the way. It allows the myosin heads to interact with those actin filaments, and then it's going to pull the system together. This is how muscle contraction works. It's called the sliding filament theory, and if you've ever looked at muscle cells under a microscope, this is why they have all those lines and stuff. Alright, I made a whoopsie daisy when I was trying to record this slide last time, so let's see if I can do this properly this time. Okay, so we talked about heart rate, or we talked about the cardiac output equals heart rate times stroke volume, and stroke volume is your preload, your afterload, and your contractility. So There's two parts of this equation though, right? We got heart rate to talk about. So let's talk about heart rate. So heart rate, it's role in cardiac output. It's the fastest variable to change, right? So like if you've ever been dehydrated or in a low preload state, you probably stood up and your heart rate was racing. Well, this is why, because remember, if this goes down, this has to go up, right? So how is your heart rate controlled? Well, you got two different systems. You got your sympathetic nervous system, which is the gas pedal. This is your increasing the rate, which increases, chronotropy is the fancy medical word for rate alteration. And then you can change the conduction velocity through dromotropy, which is how fast those electrical impulses are actually moving through your heart. And then you got the parasympathetic nervous system. It's controlled by your vagus nervous system. This is like stepping on the brakes. This decreases rate via the SA and AV nodes. And I'm pretty sure all of us have experienced maybe vagling once or twice before. It's not super pleasant. Maybe you were having a really hard fight after some Taco Bell in the bathroom and you clenched down too hard and you felt like you were going to pass out. Well, it's because you were stimulating that vagus nerve. And this is also why old people, are frequently found in the bathroom dead. It's because they vagaled and then just died. Okay, so remember, diastole is the phase where the heart fills and the coronary arteries are perfused. So if you're in like a SVT or whatever, or like a VTAC, or doesn't matter, we'll just use SVT as an example. Our heart rate is going to be like super fast, right? So like greater than 150. 105. Goodness gracious. All right. Our heart rate is going to be greater than like 150. And what does that do? Well, if your heart rate is pumping like this, how much time do you think that there is to fill that so you can actually get the preload needed? Well, there's not a lot of time, right? So that's why. So decreased filling time leads to low preload, which leads to low stroke volume, which leads to a crash. So the other thing to note here is that if your heart rate is super duper high, it'll lead to an increased oxygen demand, or MVO2, and then that's kind of what causes that demand ischemia, because your heart muscle cells like oxygen, and if they can't get that oxygen, then they start to die, and that starts to leak troponin. And that's why when someone's super tachycardic or whatever, their troponin can oftentimes be elevated. It doesn't mean that they're having a heart attack, but it does mean that there is enough ischemia. I spelled that wrong. That's my bad. Anyway, that's why that's what causes that demand ischemia, is because they're tachycardic, their heart muscle cells need more oxygen, they're not getting it. It leads to muscle cells to start to die, leaks troponin, yada yada. All right. Okay, so question 1. A patient presents with an inferior wall myocardial infarction with right ventricular involvement. You note jugular venous distension and clear lung sounds. The patient becomes hypotensive after someone administers nitroglycerin. What is the physiological cause of this deterioration? I will leave you with this for a second. Okay, I hope you guessed B, right? Remember, we talked about right-sided hearts being very preload dependent. So, when someone has an MI, their right ventricle is failing, and it requires a lot more stretch to maintain that forward flow via the Frank-Starling law. Nitroglycerin is a vasodilator that reduces that preload. So that reduction causes an immediate drop in cardiac output and blood pressure. A trauma patient has experienced significant blood loss. Their heart rate has accelerated to 160 beats per minute to compensate for the drop in stroke volume. Despite this compensation, the patient begins to crash. What is the physiological limitation causing this decompensation? Alright, I hope you guessed B. Yep. So while heart rate increases to maintain cardiac output when stroke volume drops, there's a critical threshold to that. So at extreme rates, like an SVT or whatever, the duration of diastole becomes too short. So this lack of time results in decreased filling, leading to low preload, low stroke volume, and eventually circulatory collapse. Alrighty. So a patient with left ventricular hypertrophy, stiff heart, suddenly goes into rapid AFib. Their blood pressure immediately drops from 130/80 to 80/50. Which specific component of preload has been lost? The Frank-Starling mechanism, venous return, the atrial kick, or end systolic volume? I hope you guessed C. Remember, that atrial kick is 20 to 30% of your preload or your ventricular filling. So in patients with a stiff heart, that ventricle is already dependent on that extra filling volume, and that rapid onset of AFib results in the loss of that atrial kick, which can cause immediate hypotension due to the sudden reduction in preload. All right. Yeah, that last slide came up on me as a surprise, so I'm going to actually go ahead and cut the video here so you don't have to sit here for another 45 minutes. I hope you learned something, and if this was helpful, if you wouldn't mind commenting, liking the video, and subscribing if you want more content, I would really appreciate it. Like I said, thanks for watching. You guys have a good one. Thanks.